Hello, and thank you all for joining me. Today I'll be discussing a compelling case that highlights the importance of early recognition and thoughtful management of cardiogenic shock in a patient with advanced heart failure with reduced ejection fraction, or HFrEF. HFrEF is a progressive condition in which guideline-directed medical therapy, commonly known as GDMT, has been shown to improve both symptoms and survival. However, in the advanced stages of the disease, patients may present with acute decompensation complicated by cardiogenic shock. This is a life-threatening state where the heart is no longer able to maintain adequate tissue perfusion, leading to rapid or end-organ injury. Unfortunately, GDMT often becomes poorly tolerated in this setting due to low blood pressure and worsening kidney or liver function. In such cases, short-term inotropic support may offer a critical window for stabilization, allowing the reintroduction of therapy and preserving options for more advanced interventions. We present the case of a 30-year-old woman with non-ischemic cardiomyopathy, alcohol abuse disorder, and chronic HFrEF. Her ejection fraction ranged between 25 to 30% with an NYHA class 3B symptoms, placing her at an AHA stage D. She came to the hospital with progressive shortness of breath, lethargy, and abdominal pain. On exam, she was hypotensive and tachycardic. She also had an elevated JVD, or jugular venous distension, an S3 gallop, holosystolic murmur radiating to the axilla, and cool non-pitting edema in both legs. Her BNP, brain natriuretic peptide, was elevated at 1682, while troponins remained negative. An echocardiogram showed further decline in ejection fraction to 15 to 20%, along with severe mitral and tricuspid regurgitation, and importantly, preserved right ventricular function. Her condition worsened, progressing to overt cardiogenic shock. She became more lethargic, her blood pressure continued to fall, kidney function deteriorated, and she showed signs of systemic hypoperfusion. Prompt recognition of this clinical decline was essential. GDMT was withdrawn, and she was rapidly escalated to a higher level of care. Coronary angiography ruled out obstructive coronary disease, and a right heart catheterization confirmed shock physiology, showing a pulmonary capillary wedge pressure of 44, mean pulmonary artery pressure of 43, a cardiac output of 3.5 liters per minute, and a cardiac index of 1.8. A Swan-Ganz catheter was placed for continuous monitoring, and intravenous Milrinone was initiated at 0.25 micrograms per kilograms per minute. This resulted in improved perfusion and hemodynamic stabilization over time. Once she became more stable, GDMT was cautiously reintroduced through the cardiology team while Milrinone was continued, aiming to optimize her candidacy for a transcatheter mitral valve edge-to-edge repair, or MTER. This case illustrates two critical takeaways in the management of advanced heart failure. First, the importance of recognizing overt cardiogenic shock early. Clinical signs like hypotension, worsening mental status, and kidney dysfunction must be rapidly integrated with hemodynamic data to guide immediate intervention. Delayed recognition can lead to irreversible organ damage and loss of therapeutic windows. Second, while chronic inotrope use is generally associated with poor outcomes, carefully selected patients may benefit from short-term support. In this case, Milrinone served as an effective bridge, helping to stabilize the patient, safely reintroduce GDMT, and maintain eligibility for advanced therapy. Milrinone was specifically chosen for its inotropic and vasodilatory properties, features especially useful in the setting of elevated filling pressures and pulmonary hypertension. Ultimately, this case emphasizes the value of individualized and personalized hemodynamic guided therapy in end-stage heart failure. Recognizing and stabilizing cardiogenic shock can shift the patient's trajectory away from futility and towards recovery and advanced intervention. Thank you.